Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AbbVie.
So, I want to welcome you all to this program, Between the Lines of Depression Navigating Diagnostic Nuances and Treatment Strategies. I'm Anita Clayton, the Wilford W. Spradlin Professor in the Department of Psychiatry and Neurobehavioral Sciences and Professor of Clinical Obstetrics and Gynecology at the University of Virginia School of Medicine in Charlottesville, Virginia. I'm joined today by Manpreet Singh, the Robert H. Putnam Endowed Chair of Bipolar Research and Treatment in Psychiatry and Behavioral Sciences at the University of California, Davis in Sacramento, California.
Delighted to join you today, Anita.
Let's look at a video of a patient's journey with depression to start off, and then we'll have conversations about how we might respond to such a patient.
I first noticed my depression anxiety in my early teens, but I wasn't diagnosed and didn't see a professional until my early 30s. I wasn't diagnosed with any other condition prior to getting my official diagnosis related to my depression symptoms. I think I have been screened for the possibility of bipolar disorder, but I don't remember exactly. Um, it's also been my experience that you're not always told exactly what you're being screened for. I believe I was, but I can't say for sure. So, unfortunately, my treatment has not been effective for depression or anxiety. I have tried a lot of different medications, including multiple medications at once. I wasn't concerned about being overly medicated, more just concerned about how to be aware of efficacy or lack of efficacy. Um, I have never been offered an atypical antipsychotic medication. If I were offered one and was explained why it'd be worth considering and I had full disclosure around the side effects, then I would not be opposed to trying one if there's the hope of it being effective and successful. I do think the stigma of needing medication and not feeling better from medication is something that I struggle with, but not about taking medication. Unfortunately, all of the long-term medications that I've tried have had really negative physical side effects for me. I do think there may have been some improvement in my depression with some of the longer term meds, but the GI and nausea side effects were so significant. And I did feel some lethargy as well with some of those medications. I would definitely be open to trying other medications. I have been prescribed different types of anti nausea medication in concert with my depression medication, but even at extremely high doses, like doses intended for cancer patients, I still have nausea and GI upset. Part of my depression includes insomnia. And while the medications I've tried have made me feel lethargic and low energy, they haven't improved my sleep, which feels like a double-edged sword. So I'm tired and feel drained, but then I can't sleep. And I also have a job that I'm on call overnight. So it's also difficult for me to find a balance between finding a medication that kind of effectively knocks me out, but also I can be responsive to my job responsibilities overnight. So it's a tough balance. I think it is important for clinicians to be very transparent and explain what you are being screened for, especially for people with anxiety or its anxiety disorders. It can feel very scary to not really know all the information. So, I think stronger communication around what you are being screened for or have been screened for, or what those findings are, especially in layman's terms, is really helpful.
So this was a very interesting video, I thought, Anita. I was very impressed by the patient's ability to talk about her anxiety. It reminded me that when patients present with a spectrum of mood disorders, how important it is to frame the interview so that they understand what's coming, that you are going to be looking at their mood symptoms, anxiety, as well as other co occurring conditions very thoughtfully and carefully. That helps alleviate the potential questions that this patient.
And I agree with you. And I think the other thing is that the patient feels heard. And so these comments we're talking about might help with that. But I think also understanding what her concerns are, which in her case were one, nausea about the antidepressants that she's been tried on, and two, insomnia as a symptom of her depression and wanting those things to be treated. So, how do you differentiate between bipolar 1 versus bipolar 2?
It's a great question. There are very clear diagnostic criteria that are available in the Diagnostic and Statistical Manual. The main difference between bipolar 1 and bipolar 2 is time and intensity of symptoms. In mania, you have to have a history of mania for at least more than a week or be hospitalized because of the symptoms and their impact on functioning. Hypomania is fewer days, at least 4 days or more of mania, and are somewhat milder. So, helping to explain what that differences can help patients also understand the episodic nature of bipolar disorder, where patients experience both highs and lows. So I try to ask every patient who presents to my clinic about all moods, highs and lows, so that I can make the distinctions between bipolar 1 disorder, bipolar 2 disorder, as well as bipolar depression and unipolar depression. That's sort of how I start the conversation, but happy to elaborate.
Well, would you review the efficacy data on atypical antipsychotics in bipolar depression?
I sure can. And just a footnote on the diagnostic criteria. I sort of talked in overarching principles about how I go about making a diagnosis or coming to a diagnosis. It's a way to streamline the interview. And what we know is that for bipolar 1 depression, that is anyone who's had a lifetime manic episode, but is currently feeling a depressed mood lasting at least 2 weeks, where 50% of the day, every day or more, they're experiencing a low mood or lack of interest in the things that are fun for them, as well as some associated symptoms. We like to use the mnemonic SIGI caps commonly, which addresses sleep, motor function, appetite, as well as a presence of suicide, concentration, and cognitive difficulties included. So once you go through those symptoms and you've determined that a patient has bipolar 1 depression, you might choose there up to 5 different treatments that are US FDA approved, including cariprazine, lumateperone, lorazepam, the olanzapine fluoxetine combination, and quetiapine. All 5 of those medications are approved for bipolar 1 depression. There is a bit of a nuance if you have hypomania, but not mania. For those patients who've not experienced a lifetime manic episode, but may meet criteria for bipolar 2 depression, where they have hypomanic episodes lasting anywhere between 4 to 6 days, they might be improved by lumateperone or quetiapine. Those are the US FDA approved treatments. I tried very hard to start with the US FDA approved medications, A, because there's a great literature that I can reference and share with the patients that demonstrate that efficacy and safety profile, and we have that stamp of approval. There are also US FDA approved treatments for adjunctive major depressive disorder. So, for adjunctive unipolar depression, where there is no evidence of lifetime mania or hypomania, you might choose aripiprazole, brexpiprazole, and cariprazine or quetiapine. Those are adjunctive treatments for unipolar depression that are FDA approved to be used in addition to a primary or background antidepressant. But one thing I do recommend is when you prescribe an antidepressant, always evaluate for emergent mania or hypomania, including whether it's treatment emergent. It's very important that we not miss that association and potentially avoid antidepressants when necessary. There were some medications that we have had around for a long time, like lamotrigine, for example, that has been very commonly used off label for bipolar depression, but has not shown consistently across studies efficacy in bipolar depression. I generally tend not to use lamotrigine when I have all of these other options that I've described to you already. And I think it's useful when you have question about these emerging treatments to really look at the primary studies. There's several studies now that have actually been conducted using these more recently approved treatments like cariprazine and lumateperone. They used the Montgomery-Åsberg Depression Rating Scale, or the MADRS, to evaluate for efficacy and beat placebo in most cases with significant effect sizes. So both cariprazine and lumateperone have established efficacy in bipolar depression and are um, uh, seeming useful both in a monotherapeutic setting for cariprazine, for example, and even in an adjunctive setting in the case of lumateperone. So these are important studies to review, and it's also useful to keep in mind that these studies give you some guidance on how to dose these treatments. And I just want to convey that one of the things that both of these new medications have done is provided relatively simple dosing strategies. In fact, it's very clear that we have medications that, for example, in the antidepressant world, to treat depression, where you have to do a titration over oftentimes several weeks. Cariprazine and lumateperone have starting doses. Cariprazine at 1.5 milligrams, but can be dosed as low as 0.5 or 1 milligram and ramp up to 1.5. Studies have suggested efficacy at 1.5 milligrams and 3 milligram doses. When you start to go higher with cariprazine, we begin to see, unfortunately, more side effects related to a metabolite, DD-CAR, that then at higher doses tends to hit the dopamine 2 receptor in terms of blockade, rather than the primary mechanism of action, which is focused on D3, the dopamine 3 receptor. And it's important to also note that cariprazine in small retrospective observational studies did show efficacy in treatment resistant bipolar 1 and 2 depression. There was a significant response in HAMD with almost a 50% response rate. There's some discussion about lumateperone. Its starting dose is 42 milligrams, and really it is a single starting dose, and that's usually where people live with this medication. Very easy to dose and showing efficacy in both monotherapy and adjunctive contexts. I think I just want to kind of reach back out to Anita now at this point, and maybe you can share some some experience with use of cariprazine and lumateperone in bipolar depression.
So, a couple of things related to bipolar depression. I absolutely agree that single dosing is way better than any other dosing that you need. And when the starting dose is the effective dose, that's also a benefit for patients. So, we generally start people on cariprazine at 1.5 milligrams daily, and we don't move from there. Occasionally, someone will ask us if they could go up in the dose, and we try 3 milligrams. I've had people come in on 6 milligrams. There's no benefit that I've seen that's positive there. So we have backed those people down. We've deprescribed from those higher doses. And with lumateperone, I do start at 42 milligrams daily, but I have a number of patients with bipolar illness who frequently have depressive episodes, and those patients often don't tolerate that 42 milligrams, and I reduce it to 21 milligrams. So I think we need to broaden our thoughts about these two drugs, which are fairly unique in their mechanisms of action, that lower doses may in fact be better. And so definitely these are medications I might start on somebody who presents with a depression but also appears to have um, uh, bipolar type experiences in their past.
Well, I'd love to switch gears and ask you more about the situation of when do you switch and when do you augment, Anita?
Yeah, so I think that the data has been somewhat surprising about switching if someone has no response or if somebody has a partial response versus adjunctive therapy. I think probably the key is tolerability. So in fact, if people are not tolerating an antidepressant you've tried them on, then I don't think it's useful to continue on that and add something else in, obviously. I think if they don't have a response, I might consider switching right off. But if they have a partial response, I probably would go ahead and um, try an adjunctive treatment in them, and we can discuss those options. I think also the issue of having had an adequate trial on a given medication is really critical. I've had many people come in and say, I've been on everything. And when you
Mhm,
go through their history, they've been on nothing because
mhm.
they'll take something for a couple of days, they'll have a side effect, they'll stop it and get switched and various other things. So we have no real information except either they're anxious and they're way more aware of side effects, or they actually have um, pharmacogenomic mutations that cause them to metabolize a lot of medicines very slowly, and they may be the doses may be too high for them. So I think those are key. 6 weeks at an adequate defined dose it could be considered an adequate trial. Less than that, no.
What do you make of the differences between cariprazine and lumateperone and how the trials have played out in the adjunctive MDD context? It sounds like we've got some favorable support for cariprazine for adjunctive utility, but it sounds like the jury's out for lumateperone.
For adjunctive treatment, we have approval of some pretty conventional second generation, but early on, aripiprazole and brexpiprazole as an add-on to an antidepressant, and quetiapine too. Now, the
Okay.
studies in quetiapine really were monotherapy for
Yep.
quetiapine and major depression, but the FDA couldn't handle that idea, and so uh, they made it so that it was adjunctive treatment. But I think, yes, cariprazine has been approved in adjunctive treatment for MDD, and the lumateperone has all the data. It's just in front of the FDA right now. And as we said before, both of these are well tolerated and single once a day dosing. And I think that that can make a huge difference, especially when we have somebody already taking an antidepressant, hopefully once a day as well.
Yeah, a really good point about the dosing strategy and how that might align with patient preferences. Most often, I see patients saying, can I take it at the same time, this adjunctive treatment? And if it's only once a day, then that might not be as much of a burden to the patient than perhaps multiple dosing in the course of a day, which could really impact a patient's lifestyle.
And I think really when you're looking at the options that have approval or about to get approval for adjunctive MDD treatment, most of those would be dosed in the morning. We should consider the two um, medications together. So when do they take the antidepressant and what are its mechanisms of action? And then what would we prescribe to let them take those two together?
Anita, you mentioned mixed features earlier, and I wonder if we want to maybe talk about that a bit before we also discuss side effects. And many people will raise concerns about antidepressants potentially inducing mania. We talked about the importance of potentially avoiding using antidepressants monotherapeutically. Anyone who has a history of hypomania or mania really reserve a lot of caution in that context. And the reason why is because antidepressants have been established to um, present with higher rates of mixed features and have induced mania and hypomania in a variety of different observational studies. Retrospectively, we've seen it, and we see it when we track patients prospectively too. Another reason why it's so important to assess for mania and hypomania that might be treatment emergent. The nice thing about some of the medications that are currently have recently received approval is when you do post hoc analyses of the clinical trials that have recently been published, you find that even though the populations that were studied were clearly in a depressive episode, the hypomania that might be in the background, even as minimal as it was to enter these studies, were also benefited from these medications. We saw this in post hoc analyses for cariprazine, lumateperone, where mixed features seem to be addressed very nicely, whatever symptoms of hypomania and mania. And that even though that wasn't the primary goal of these trials, where the focus was principally on treating the depression, none of these medications themselves looked as if they were associated with treatment emergent mania. Thank goodness that we can feel rest assured that those medications, cariprazine, lumateperone, most recently, uh, did not really seem to be associated with any a treatment emergent mania, and looked as if they were also potentially perhaps helping. I'm curious if we want to broaden the discussion actually about side effects at this point. So, what are the major side effects that we have to worry about for these US FDA approved treatments that we do have available for bipolar depression?
Yeah, so the things I mentioned uh, are important. So weight gain more than 7%, extrapyramidal symptoms, because we do see those with antipsychotic medications, somnolence, akathisia. That's probably one of the most problematic adverse effects because patients don't really understand it until they've discussed it with you. And it's pretty intolerable not to be able to sit still. Nausea is a common adverse effect of a lot of psychotropic medications. And the key here is how does it impact their quality of life? And does it cause them to be non adherent to treatment or request a treatment change? So, when we're looking at things like quetiapine, which we've had around for a long time, weight gain can be a problem, and people will discontinue because of that. It can cause somnolence at very requiring very few patients in terms of the number needed to harm in order to see that. If we're talking about lorazepam, which is also been around for a while. Weight gain is not a significant problem there, but things like extrapyramidal symptoms, somnolence, akathisia, nausea, and especially at higher doses may limit our use. And then cariprazine really and lumateperone very similar, not causing weight gain, not causing extrapyramidal symptoms, at least not commonly. Somnolence occasionally is seen with lumateperone, and when people have that, then I want them to take it at night. And akathisia can also be seen with cariprazine. So
At
we
higher
might,
doses.
yes, at higher doses. So we may need to add something or drop back to the lower dose if we've upped the dose there. They're not generally associated with nausea or discontinuation because of adverse effects, which is a very positive thing, especially in the individuals who tell you that they get adverse effects to everything.
And what about the adjunctive context? The FDA approved treatments are a bit different for adjunctive MDD. What are the landscape of relative risks versus benefits there?
Yeah, so with aripiprazole and brexpiprazole, not usually problems with weight gain, not usually problems with somnolence or sedation, but akathisia can be seen. And that is also true for cariprazine, as we don't see weight gain, we don't see somnolence or sedation in general, but we do see akathisia. When we're talking about olanzapine fluoxetine, and this is really approved for treatment resistant depression, we do have problems with weight gain. We do, to some degree, have issues with somnolence or sedation, and that's why it's given at night, but not problems with akathisia. And then quetiapine, we know, uh, isn't really associated with a huge amount of weight gain, interestingly enough, but it is associated with somnolence and sedation, and not so much with akathisia either.
And what do you see coming down the pipeline for lumateperone?
For the adjunct treatment of MDD, in the phase 3 pivotal trials of lumateperone as an adjunct to major depression, which hasn't yet been approved by the FDA, we saw treatment emergent adverse events with an incidence greater than 5% and more than twice that with placebo in things like dizziness, somnolence, dry mouth, nausea, diarrhea, fatigue, tremor, the kinds of things we see with a lot of medications. And some of that may have to do with what antidepressants that was added to. Also, weight and body mass index remained stable, and there were definitely no notable changes in extrapyramidal symptoms, prolactin elevations, or cardiometabolic measures. With
Makes great sense. I also try to think about residual symptoms because I see a lot of patients with um, principally sleep and anxiety problems that aren't adequately treated in the context of bipolar disorder, especially making sure that I've already fully optimized my primary mood stabilizing agent, whether it's a mood stabilizer or if a second generation antipsychotic that's principally serving in an anti-manic role. I address and make sure that any sleep, residual sleep and anxiety problems are also addressed. And that might impact the way that I consider my next dosing strategy or also selection of a medication, where perhaps medications that are now recently approved for bipolar depression might be able to cover more of the totality of the disorder. I find a lot of patients who present, particularly post hospitalization, where they've been recently mood stabilized, experiencing significant anxiety, insomnia, difficulties reintegrating into their job or school functions, and perhaps might consider the value of the data that we've seen post hoc in some of these newer agents that suggest a more stabilizing role in the mixed features context. Anxiety anhedonia, attentional dysfunction, irritability, or anger. These are all symptoms that are reflected in mixed features. In the patients that I see who might be experiencing these residual symptoms, I do like to think about mixed features as part of my differential, and also my treatment planning discussions with patients, and help them see potentially hope. So those are the things that I think about when I'm trying to weigh the options for patients who have residual symptoms. Physicians might be listening in and might be wondering how in the world to orient themselves to these complex symptoms. Maybe they might even wonder when a referral to one of us might be useful. Do you have any tips for that, Anita?
Honestly, I'd prefer to be consulted earlier rather than later. I
Mhm.
know most primary care providers are not comfortable with long-term treatment or making the initial treatment decisions. And I usually just want to say, okay, we're going to start with a mood stabilizer or we're going to start with an atypical antipsychotic because one of those is going to help us prevent anything else from happening when we're adding something to maybe target depression, for example. It's probably most helpful if you have a relationship with a psychiatrist in which you can contact them and say, this is one of those cases where I feel like they need to be seen quickly. If they know that you know when to really say this is an urgent referral, I think most of the time people will work around that. And I have given advice to them about potential treatments for such a patient. It can be difficult. You don't want to say specifically for this patient, do this, but you can say for patients like this, when I see them, I would normally start this and to
Yeah.
do that, and then let's uh, get them in as quickly as possible, and we can make adjustments there.
Yeah, I think you're reflecting a lot of the efforts that many psychiatrists are trying to make to be consultative if they're impacted and can't get someone in quickly to be able to provide quick suggestions on things that might be good general guiding principles. I do think that the presence of mania or hypomania can complicate a unipolar depression course, and so might be a point of referral just outright. But for some practitioners who are beginning to understand these principles that we're describing in these continuing medical education activities, they might begin to think about what is US FDA approved, look to the literature, and if there are questions about dosing, usually you can find that in the package insert, but highly recommend that if you're feeling that you're out of scope of your practice, that reaching out to a colleague is very reasonable, and referrals generally are accepted, and can be expedited, like Anita said, when you signal certain, concerns, whether it's related to treatment failures or symptoms that raise concern, or potentially the dynamic way in which the symptoms are unfolding, which can potentially also lead to a visit to the emergency department, urgent care, or hospital.
I think also ensuring their safety is at the top of our list, which is why we would try to get patients in relatively quickly or a referral or sending them to the emergency department, especially with thoughts of suicide.
You bet. Well, Anita, thank you so much for this great discussion. I've very much enjoyed it and learned a lot from you, and hope the audience here has enjoyed it as well.
Thank you, Manpreet.
Thank you for participating in this activity. I hope you find some useful tools and resources on the right hand side of this page. Thanks again.